Ovarian cancer, where are we today? And this will be presented by Professor Ibtisam Saaduddin, Professor of Clinical Oncology, Cairo University, and one of the leading members of the Ovarian Cancer Department or Unit in Asrain. Dr. Ibtisam, please.
Thank you, dear colleague, Professor Mohsen Mukhtar, for your nice presentation. And first of all, I would like to thank Roche Pharmaceutical for organizing this symposium that would hopefully help us all to update and refresh our knowledge in an important topic in oncology, the ovarian cancer, especially at later stage. Before going through the details of therapy, I'm going to throw some light as the magnitude of the problem in all. Actually, epithelial ovarian cancer is the leading cause of death from gynecological cancers in the States. And in the year 2013, more than 22,000 patients were newly diagnosed. Unfortunately, less than 40% of women with ovarian cancer are cured. However, the incidence of ovarian cancer increases with age and is most prevalent in the 6th and 7th decades of life. More than 70% of patients present with advanced disease, and this is the problem. In an Egyptian publication by Professor Hussein Khalid and colleagues, ovarian cancer was among the 5 top cancers in females. However, there are several challenges in managing ovarian cancer in clinics. Some of these challenges are related to the patient, mainly the presence of risk factor, the age, and diagnosis and performance status, while others are related to the tumor, mainly the figo stage, the histology, the grade, and the genetic features. Of importance is the surgical expertise that has an impact on the extent of residual disease. Several risk factors are implicated in developing ovarian cancer. Some of these factors are associated with increased risk, such as nulliparity and hormone replacement therapy, while some factors were found to be protective, as oophorectomy and hysterectomy. Ovarian cancer is most frequently diagnosed in women in the mid-50s to mid-60s, with the highest rate of mortality occurring with older age in women in mid-70s to mid-80s. Performance status was found to be of paramount importance as a predictive prognostic factor for ovarian cancer as regards its impact on both overall and progression-free survival. This slide, most of us are aware with it, shows the last FIGO staging for the year 2013 for advanced stage ovarian cancer. Actually, as this graph depicts the impact of FIGO stage on patient survival, and here we can see that the lowest survival was, as expected, associated with a later FIGO stage as compared with patients diagnosed at an earlier stage. Further analysis of prognostic factors by histology have shown that patients have different histologies, and comparing different histologic subtypes to the standard serous papillary carcinoma of the ovary, it was found that both the mucinous and the clear cell types had poor impact on both progression-free and overall survival as compared to the serous papillary carcinoma, while endometrioid subtype had a favorable impact on both the overall and the progression-free survival. And we can see here that the hazard ratio for the endometrioid versus serous was strong, 0.77 in favor of the endometrioid subtype, while the mucinous was a hazard ratio of 1.76 and was considered, of course, of poor impact on overall survival and progression-free survival. On further analyzing the outcome by grade as an important prognostic factor, as expected, higher grades have poor outcome in both the overall and progression-free survival. We can see here in these curves the relation of survival, as we have mentioned, by the amount of by the extent of surgery and the presence of residual disease. In patients with a minimum residual disease of less than 0.5 centimeters, what we say microresidual, we can see that these patients had the highest overall survival, while patients with a residual disease of 2 centimeters at least or more had the worst overall survival. And here comes the impact of